Well, welcome everybody. Thank you for joining our webinar tonight. My name is Lauren Steffes, and I'm the marketing specialist here at OSMS. Tonight we have Dr. Brandon Stradel with us to talk about shoulder arthritis, specifically common shoulder issues, how arthritis develops, and your treatment options. Dr. Stradel is fellowship trained in shoulder surgery, so he'll be able to provide a lot of insight on this topic for you all tonight. Just so you are aware, we are recording this webinar, and we'll make the recording available on our website at osmsgb.com/webinars by next week. If you have any questions during the webinar, please feel free to leave it into the Q&A box, and we'll make sure to address your questions at the end of the presentation. Before I turn it over to Dr. Stradel, I just have a few things about OSMS that I'd like to go over, and then I'll turn it on over to him. So OSMS is a doctor-owned orthopedic, sports medicine, rheumatology, and pain management practice. We have 9 locations across Northeast Wisconsin, making it convenient for you to schedule an appointment where it's best for you. We have 25 orthopedic physicians. That includes surgeons and non-surgical physicians, 10 rheumatologists, 3 pain management physicians, and then a spine surgeon. We also have a full range of services all in one location. So for rheumatology patients, we have infusion treatments. And then we have our 2 surgery centers in Neenah and Green Bay. If you have surgery at one of our surgery centers compared to a hospital or hospital-owned surgery center, you can see up to 40% in cost savings. And then with our walk-in injury clinic, those are also located at our Neenah and Green Bay clinic. You can see up to 94% in savings simply because we charge it as if you had an appointment. So with our walk-in clinic, you can walk in without an appointment and you're guaranteed to see an orthopedic physician. We charge it as if you did have an appointment, and that makes it a lot more cost savings rather than going to an urgent care ER. And then we also have physical and occupational therapy partners on site at our clinics as well. And then we also have all the diagnostic services that you may need to get your conditions diagnosed. So that includes X-ray, MRI, CT scans, DEXA scans, which is bone density, and then EMG. We know that not all injuries happen 8 a.m. to 5 p.m. Monday through Friday. So if you have a pain or an injury that you're just not sure whether you should go in and be seen, or it happens on the weekend when we're not open, you can utilize Ortho Access by OSMS. It is a free 24/7 chat where you can get connected with an orthopedic expert, and they'll be able to provide you with advice or guidance on what you should do, whether it's try these at-home remedies or, oh, that's something that you should go in and be seen for. Let's get you an appointment. And then last but not least, we do have extended hours. So in our Green Bay clinic and our walk-in clinic, right now, Monday through Friday, 8 a.m. to 7 p.m., we are open. And then Friday, 8 a.m. to 5 p.m. Right now, our Fox Valley clinic and walk-in clinic hours are as following. But just to let you know, after January 1st, 2026, our Fox Valley hours will be consistent with our Green Bay hours. So being open later Monday through Thursday, and then 8 a.m. to 5 p.m. on Friday. Now that I have shared a bit more about OSMS, I'll hand it on over to Dr. Stradel to discuss shoulder arthritis. Dr. Stradel?
Great. Yeah, thanks, Lauren. Thanks everybody for joining us tonight, and great to be able to talk about shoulder arthritis and provide some of my insight and expertise on this area. So like Lauren said, I have a fellowship training in sports medicine and shoulder surgery specifically. So this is kind of a topic that's of particular interest to me. I am local, so went to Denmark High School, so it's good to kind of finally be back close to home. I did my medical school training with Medical College of Wisconsin in Green Bay, residency at Western Michigan, and then fellowship with the University of Minnesota. Just some of my personal interest, wrestling, combat sports, longevity, and education specifically. So a little bit of an outline. I'll talk a little bit about shoulder anatomy, shoulder arthritis, some of the treatment options, and then frequently asked questions. And then we'll have time for some questions at the end as well. So the shoulder is a fairly complex joint. There's a lot of different pain generators, around the shoulder, a lot of things that can cause, pain or dysfunction. These involve the biceps tendon, the rotator cuff. There's something called frozen shoulder. Really tonight specifically, we'll talk kind of detailed about shoulder joint arthritis, kind of specifically. And then, in future webinars, we can address some of these other topics as well. So looking at the shoulder joint itself, it's a ball and socket joint. So there's a, spherical head, the humerus that articulates with the socket, or the glenoid is what we call it. The shoulder has the most range of motion of any joint in the body, as well. It's important to distinguish that, you can have shoulder arthritis of the ball and socket joint, but you can also have arthritis where the collarbone meets the rest of the shoulder at the acromioclavicular joint is what we call it. That's AC joint arthritis. And those are two distinct things. We'll kind of focus more on the shoulder joint arthritis, this evening. And then just, a little bit on the rotator cuff muscles. So the rotator cuff, there's a group of muscles that all originate on the shoulder blade, and they wrap around to the humerus, or the ball portion, and they help stabilize the shoulder and power the shoulder, through a range of motion. So, shoulder arthritis, so what exactly is arthritis? It's a degenerative joint disease of the shoulder joint, really characterized by damage to the cartilage surfaces of both the humeral head, or the ball, and also the glenoid, or the socket. So it's really the loss of the cartilage. The cartilage is the smooth gliding surface that allows the shoulder to move through a range of motion, in a smooth fashion. It kind of cushions the bone, so you're able to do that. This picture down on the right, that's a picture of normal looking cartilage. So it's kind of smooth, white, and glistening. So that's what it's supposed to look like. And on the bottom left picture here, you can just see some of the structure. This cartilage, it's a highly organized, structure that plays a very specific role. When we look at x-rays of the shoulder joint, so, if anytime you would come in for an evaluation, we typically get shoulder x-rays. They give us a good idea of how much joint space is left in the shoulder and whether arthritis is, something on our differential of what could be causing pain. On the left picture, you see a normal looking x-ray. So this is kind of a front view looking at the shoulder joint. You can see the ball in the socket. And there's a normal joint space there between the two of them. And inside that joint space that you see on x-ray, that's where the normal cartilage would be. And then if you contrast that with the image on the right, you can see there's a complete loss of that space. You start to see bone spurs develop, kind of on the bottom portion of that humeral head, as well. So that's a pretty classic x-ray of what arthritis would look like in the shoulder joint. So what causes arthritis? We kind of think about it in terms of like primary and secondary causes. So primary cause of arthritis would just be the mechanical breakdown and thinning of the cartilage over time. But there's also secondary things that can lead to arthritis. It could be traumatic or post-traumatic, like if someone had a history of a fracture, a dislocation, that altered the mechanics of the shoulder or caused some injury to the cartilage, at the time of the injury. We know there's inflammatory arthritis, so something like rheumatoid arthritis, where it's more of an inflammation of the shoulder joint can lead to damage to the cartilage. Some patients have long-standing rotator cuff tears that can alter the mechanics of the shoulder, because if they don't have the rotator cuff there to function and hold the shoulder in place, there's more motion and the cartilage sees more stress. And those patients can develop something we call rotator cuff arthropathy. And then there's other lifestyle, things that can contribute. We found, over the years that genetics play a pretty large role in the development of arthritis, not only in the shoulder, but, kind of throughout the body. Obesity, and inflammatory diet can all contribute to the development of arthritis. And interestingly, we see higher rates of arthritis in our female patients, at about a 1.5 to 2 times multiplier. We think some of that maybe, we also see higher rates of rotator cuff issues in our female patients. Some of that may be, just hormonal differences, just something to note. So what are common signs and symptoms of shoulder arthritis? like I said, there's a lot of different pain generators in the shoulders. There's a lot of things to think through, but shoulder arthritis classically causes kind of a dull, achy pain deep within the shoulder joint. And stiffness is kind of a characteristic, of shoulder arthritis. Once you lose the cartilage, the joint space narrows down, some of those bone spurs develop, and the tissue around the shoulder just gets kind of tight. So these patients often have stiffness as a complaint. Not every patient with shoulder arthritis has stiffness, but it is one of the more common things that we see. And typically, with most shoulder pains, they often cause pain more so at nighttime and often disrupt sleep as well. I just throw this one slide in here on frozen shoulder. As we talk about stiffness, it's important. There's another condition called frozen shoulder that can cause stiffness in the shoulder. The other name for frozen shoulder is adhesive capsulitis. And this is a big inflammatory response within the shoulder that typically causes severe pain and stiffness in the shoulder. This is different than arthritis, however. We found that it's associated with a couple different endocrine conditions, diabetes, thyroid disorders. And the good news about frozen shoulder is it typically responds very well to conservative treatments, and people typically do regain their motion. It can be a long process, but usually it's responsive to therapy and injections, and patients regain their motion. So whenever someone has stiffness, we always think about arthritis and then adhesive capsulitis or frozen shoulder. But the treatments are quite a bit different for the two conditions. So I just mentioned this as well. So what are some common treatments for shoulder arthritis? So it's some of the basic things, oral anti-inflammatory medications. Most patients, will try over-the-counter medications first, Advil, ibuprofen, Tylenol, those things. Pretty safe medicines to take, kind of on an as-needed basis. If we're looking for something stronger, if people are really inflamed, we'll try a prescription anti-inflammatory. The two that I like to use are meloxicam and Celebrex. They're just a little bit stronger, a little longer acting, just a little more powerful to knock down some of the inflammation if people have a flare of pain. There are injections that we can do into the shoulder. For the shoulder, the one with the most evidence is cortisone. There's other injections like hyaluronic acid or the chicken comb injection. That's more often used, in the knee. There's limited use for it in the shoulder, limited data on that to suggest, it's efficacious. And it's kind of an off-label use in the shoulder. And then there's also platelet-rich plasma or PRP. There's also a kind of a lack of evidence for shoulder arthritis currently for PRP as compared to knee arthritis. But that's a kind of a hot topic in terms of research, and there's certainly more to come on that. And I wouldn't be surprised if we start doing more PRP, for shoulder conditions in the future as we have more research and data to support that. Another potential option is physical therapy. And what physical therapy can do is it's really about maintaining or improving motion and trying to balance the forces across the shoulder. So when you have cartilage breakdown or wear, there's just less cushion, to support the shoulder. So the more you can strengthen the muscles and kind of optimize your motion around the shoulder through the rotator cuff, through the scapular muscles, those muscles will absorb some of the load that the shoulder sees and can help decrease pain, through the shoulder. A couple other things. So people like, a common question is what kind of supplements, may be helpful. There's something called turmeric supplement. It's become very popular. They sell it at most drugstores. There's some evidence for this to suggest it acts as an anti-inflammatory or antioxidant, medication. And some studies have actually shown comparable relief to ibuprofen or some over-the-counter medications, and in some studies. Glucosamine or chondroitin may provide some relief. I think there's less evidence for those, but some people do find, that there's anecdotal evidence to support those. And then I think just living a healthy, active lifestyle can certainly reduce just some of the systemic inflammation and inflammation within the shoulder. So I recommend regular cardiovascular exercise, resistance training, proper weight management, and sleep hygiene. It's pretty much all the things you would try to do to live a healthy lifestyle. So then when do we start to talk or consider surgery for shoulder arthritis? And this can be different, depending on each patient's, individual unique circumstances. But, in general, this is kind of my phrase is, when the pain is severe enough to limit your activities and quality of life on a daily basis, then more conservative treatments have failed. Um, that's kind of the conversation I have with patients. There may be some good days where the pain is tolerable. There may be some bad days where it kind of flares up. I would say when you're having more bad days than good days, and it's resulting in loss of independence, difficulty caring for yourself, interfering with your sleep, I think that's when we start to have a serious discussion about surgical intervention. Another question that I get is, can you wait too long to consider surgery? I would say in general, no. In more advanced cases of arthritis, you can start to see wear of the socket, and that can alter the surgical plan. But I would say, generally speaking, it is still elective surgery for shoulder arthritis, and there's not usually a ton of urgency to that. I think one thing to consider too is just um, some patients, potentially you could wait too long. Um, And if you don't have, adequate support or if you're deconditioned, I think doing surgery at a reasonable time when your health is in good condition and you have the reserve and ability to rehab appropriately, I think that is something to consider. So surgical treatments, we'll talk about a few of these, for shoulder arthritis. Kind of the mainstay of treatment for shoulder arthritis is shoulder replacement surgery. So in the middle here, there's two main types of shoulder replacements, and I'll talk about a third option as well. There's an anatomic shoulder replacement, and then there's also something called a reverse shoulder replacement. So an anatomic shoulder replacement, for this, make an incision over the front of the shoulder, expose the shoulder joint, and then the arthritis is surgically removed, and metal implant is placed to replace the head component, and then the socket is resurfaced, and then a high-grade plastic liner is secured to the socket portion. So you're basically removing the arthritis and replacing it with metal and plastic implants. The important thing about an anatomic shoulder replacement is this requires an intact rotator cuff. So oftentimes we can get an idea of if the rotator cuff is functioning just based on someone's physical exam, whether they're able to move their shoulder, whether or not they have weakness in the shoulder. Sometimes we'll get an MRI scan to take a detailed look at it, to see if the rotator cuff is injured. Because if the rotator cuff is injured or damaged, then we talk about reverse total shoulder replacement. And around 70 to 80% of shoulder replacements in the US currently being performed are reverse shoulder replacements. So these are the majority of what we're doing now. And the reason it's called a reverse is we actually flip the components. So so we actually put a ball component where the socket was, and then we reverse the components. So these are for people that have large, irreparable rotator cuff tears, patients that may have bony erosion of the socket component as part of the arthritic process over time. Typically, if someone's undergoing a revision shoulder replacement, it's to a reverse replacement. And then in some fracture patterns where patients have a fracture, break in the bone, by the shoulder joint, sometimes we actually proceed with a shoulder replacement rather than trying to fix the fracture just because the healing can be somewhat unpredictable. We have some really great technology here at OSMS, and we've, have some partners, in the industry. So all of our shoulder replacements that we do are patient-specific custom shoulder replacements. So we get CT scans on all of our patients and use this planning software to basically plan out our component positions prior to surgery. And then we get a patient-specific guide that we use during surgery to place directly onto the socket. So we know exactly where we're putting the implants. We can be very precise in how we do that. We can remove less bone from the socket. And ultimately, if we put our implants in a good spot, it should lead to lower revision rates, less wear of the components, better range of motion, and better patient outcomes as a result of that. So this has been a really nice technology that we've had access to. What other surgical options are there? So, shoulder replacement is kind of the mainstay of treatment for shoulder arthritis. Um, and a common question people ask, well, can you put a scope in the shoulder and try to clean up the joint? I'd say there's a pretty limited role for arthroscopy in the setting of arthritis. It's best for patients that have stiffness as a, main complaint rather than pain. Um, and then, in certain instances, if people have a loose piece in their shoulder, or if they have a kind of a small bone spur that's impinging, or biceps pain, kind of in the more mild to moderate arthritic cases, sometimes arthroscopy can be an option. Um, and then I'll just briefly touch. There's also a newer kind of emerging technology. It's called a pyrocarbon hemiarthroplasty. This is a partial shoulder replacement, and it just became FDA approved in the United States just 2 years ago in 2023. They've been done in Europe for maybe about a decade now, but they've kind of become more common, in the United States. And it uses a different bearing, so it's a pyrocarbon bearing rather than a cobalt, chrome, or titanium implant that we use. And we find that there's less wear on the socket, with this component. It still has pretty limited indications. We're using this more so for like 40 to 50-year-olds, like on the very young end for what we would consider a shoulder replacement. And most of these patients that are getting these are going to ultimately need a revision surgery in the future. So it has pretty limited indications right now, but we are certainly doing these, and there's more kind of research and data forthcoming on this. So it's kind of an exciting technology for shoulder surgeons, across the country. So what does a typical recovery look like from a shoulder replacement? We put patients in a sling for anywhere from 4 to 6 weeks. We typically start physical therapy early on, within 1 to 2 weeks of surgery. That, we focus on restoring motion between the 6 to 12 week period. We start some strengthening at about 3 months. And for most people, a full recovery is about 6 months, for a shoulder replacement. We do see improvements up to a year. Most patients by 4, 5, 6 months are doing very well. Average return to work is about 10 weeks, and 22 weeks for heavy manual laborers. Desk work, computer work can be done quite a bit sooner. Outcomes, 90% of patients have good or excellent patient-reported outcomes, for both anatomic and reverse shoulder replacements. Most patients, have excellent range of motion after these and can perform some overhead activity. Some other frequently asked questions: how soon can you drive after a shoulder replacement? You need to be off of pain medication and out of a sling. It's kind of around that 4 to 6 week period. How long does a shoulder replacement last? That's a great question. Most studies predict between 15 to 25 years for the current implants that we have. And then another common question is, can you golf after a shoulder replacement? And I would say yes. And the average return to golfing is about 5 to 6 months. No significant changes in driving distance or handicap, and many patients actually improve because they have less pain in the shoulder. So how can you prevent, shoulder pain kind of in general terms? There's some risk factors for the development of shoulder pain: prior injury, uncontrolled inflammatory disease, poor posture, inactivity or weak musculature, repetitive overhead motions. So trying to limit, some of the modifiable risk factors that we have. I'd say some prevention strategies, warm up and stretching before any type of physical activity, maintaining strength and mobility of the shoulder. Um, and typically shoulder exercises, there's often a focus on low weight, banded rotator cuff and scapular stabilizing, exercises. It's low weight, higher repetition. Um, One thing I think that often gets overlooked as well is just postural exercises and then core strengthening, because that does play a role in, how the scapula sits on the chest wall and kind of the position. And then, some of the other lifestyle modifications that we had mentioned previously. We do have a number of different exercises right on our website that you can find for some at-home shoulder exercises, just for general, maintenance of shoulder health as well. So I'll kind of open it up for questions.
Yes, absolutely. Thanks, Dr. Stradel. If anyone has any questions, feel free to either put it in the Q&A area or in the chat box, and we'll address them. We already have one. How can I convince my husband that there is, in fact, something that can be done for his shoulder that does not require surgery when he always just says it's just arthritis, there's nothing they can do? He's very opposed to medical appointments and thinks he just has to deal with things. So it can be a little frustrating as has ongoing pain and reduced range of motion, as well as daily function related to his shoulder problems. Do you have any advice?
Yeah, so I mean, there definitely are treatments aside from surgery, right? So, anti-inflammatories can be good at controlling some of the pain response. Um, Injections or, like cortisone injection into the shoulder can be a more powerful anti-inflammatory, can give patients, good relief from that as well. Some of the lifestyle modifications, some of the supplements that we mentioned, and then even some of those home exercises that we have right on the website, I think is a good starting point just to work on trying to improve some of the range of motion, because we know that stiffness is, a component of the shoulder arthritis, as well. The shoulder arthritis, it tends to, like arthritis throughout the body, patients often have this period. It's kind of a waxing and waning symptom patterns. There can be periods where the pain's not too bad and things are okay and they're doing fine. And then they'll have periods where, it kind of flares up, a little more dramatically. So,
Another question is, someone was wondering if you'd be able to put the exercises slide back up. And
sure.
then also I am going to send a link to where you can find those exercises on our website as well. All right. Another question we have is, what length of time to predict injections should help?
Yeah, it's a good question too. It's kind of variable depending on the patient. When we talk about knee injections, we often quote like 3 months as kind of an average time period where injections can be effective. The shoulder is less predictable on that, admittedly. A lot of patients, I would say in general, it seems like it's less than 3 months. I would say 3 to 6 weeks is probably the kind of average time that we see injections being beneficial within the shoulder. So that's just kind of a rough time frame.
Okay.
The good thing about, injections or these anti-inflammatories is if you combine them with, some of these exercises to try and optimize the shoulder function, reducing the pain can it really improve your function to the point, because some people aren't able to tolerate doing much with the shoulder or exercises. So sometimes an injection or an anti-inflammatory can really help address some of the underlying stiffness.
Great, good to know. At what point should someone see a doctor regarding shoulder discomfort or pain to determine if it's arthritis?
Yeah, I would say I would say try some of the basic things, over-the-counter anti-inflammatories, activity modification, giving it some time, because a lot of these aches and pains, can be, transient. So, shoulder flares up for a few days and then, it'll kind of self-resolve. I'd say if it's becoming persistent and you're noting, more days than not where you're having shoulder discomfort, then I would say that's a good time to be evaluated. I'd say if you're having weakness in the shoulder, that's usually kind of a red flag, or, something that we get concerned about, to seek an evaluation as well.
Okay. Do the anti-inflammatories and exercises have the same impact if it is OA versus RA problem? So osteoarthritis versus rheumatoid.
So typically, yes. We see less stiffness with rheumatoid arthritis because it's actually an inflammatory component of like the joint lining or synovium. I would say getting the rheumatoid arthritis, treating the rheumatoid arthritis is kind of the critical component of that. You still do see cartilage wear, so treating the rheumatoid arthritis won't necessarily reverse the cartilage wear, but it can prevent further degeneration of it, um, uh, and kind of slow down that process.
Okay. What are some common early warning signs of shoulder arthritis that patients should look out for?
Yeah, I think, typically it's kind of that dull, achy pain, that patients are going to get kind of deep within the shoulder. And then I think, certainly if you're having stiffness, I think those are kind of the big, things. A lot of other things that can cause pain around the shoulder, the rotator cuff is a big one. Typically, patients with rotator cuff injuries or tears, they'll have decreased motion, like decreased active motions. They just can't lift their arm like over their head or something like that. And then they have a lot of weakness. So, a lot of patients with arthritis still have maintained strength. They just have stiffness, as a result of the arthritis.
Okay. Is it better for someone to start out with a rheumatologist and then they would refer to a surgeon if it's warranted?
Um, I mean, we work closely with our rheumatologist, as well. I think either is fine. There are some different, looking at x-rays, you can see some differences in terms of rheumatoid versus osteoarthritis. Both lead to cartilage loss, within the shoulder. And, certainly we ask a lot of the questions too. So, if you saw one of the orthopedic surgeons, we would have a good idea of if it was arthritis because of rheumatoid disease. So, I think either way is fine.
Absolutely, yeah. Um, if you end up going to a rheumatologist or an orthopedic surgeon, like Dr. Stradel said, our physicians do a really good job at making sure that you are referred and getting the treatment from the right physician that you need, which is why it's nice that we have all of that in one house for you all to go to.
Yeah, and I mean, we frequently talk to one another. I'll pop into rheumatology down the hall and run something by them, or ask them, say, hey, I'm going to send this patient over. So
Mhm. Very collaborative care. So if you do find that you have rheumatology needs and then you also need to have an orthopedic surgeon, they're going to go back and forth together and make sure to collaborate on your care. Make sure that it's the best unique care that is going to be good for you. Um, we have a question asking, why would there be pain in the upper part of the arm at all?
hmm, like so one thing that can cause pain kind of on the top of the shoulder could be that AC joint arthritis, that I mentioned kind of pretty early on in the talk. That's where the collarbone meets, the rest of the shoulder. A little hard to see on these images here, but it's the acromioclavicular joint. That's a very common place that people will also get arthritis or degeneration of that joint. And that can frequently cause pain, right on the top of the shoulder, as well. Another thing we can see is pain, right in the front of the shoulder. That can be commonly from the biceps tendon, as well.
How can patients differentiate between shoulder arthritis and other causes of shoulder pain, such as rotator cuff injuries?
Yeah, so there can be, I guess I'll preface that by saying there can be significant overlap between a lot of these conditions, the anatomy. It all kind of works as a functional unit, and everything's connected. The biceps pain a lot of times is, kind of in the front of the shoulder is typically where we see biceps pain or pain right in the front of the arm as well. Um, Rotator cuff tendinopathy or inflammation or rotator cuff tears, patients will often have pain, trying to do overhead activity. Oftentimes their pain is kind of more on the side of the shoulder. Um, and can go down the side of the arm. And if patients have a big rotator cuff tear, they'll either have loss of active motion, so they can't really lift their arm, above their head, for example, or they'll have significant weakness, with certain shoulder movements because they have a tendon tear and the muscle isn't able to fire properly to maintain their strength. Um, Whereas shoulder arthritis, oftentimes they have maintained strength. It's more of a dull, deep, kind of achy pain in the shoulder, worse with more activity, and then some stiffness.
Now, you mentioned length of time to return to a sport like golf.
Mhm.
Is there a difference between returning to any other sort of activities like weightlifting or any like pickleball, any different sports like that?
Yeah, I would say, I mean, in general, I would say that kind of 4 to 6 months range for most things is kind of a normal return to sport kind of period. When we do these shoulder replacements, we repair one of the rotator cuff muscles in the front of the shoulder. So a lot of the rehab is dictated by getting that rotator cuff muscle to heal, which that's kind of the rate limiting step for rehab. Because if we push it too fast, we might not get that rotator cuff tendon in the front to heal,
Mhm.
and that can jeopardize the outcome. So I'd say kind of in general, it's that 4 to 6 month range. Certainly lower body exercises, strengthening, cycling, even running, that stuff can kind of start sooner,
Okay.
than that time frame. But most of the upper body, uh, exercises or involvement is kind of in that 4 to 6 month range.
Great. Um, if there are both shoulder and knee issues requiring surgery, what do you suggest to be fixed first?
Yeah, that's a good question too. A lot of times it just depends on the severity, of the um, how much it's limiting or which one is more painful. Oftentimes we see that shoulder problems tend to disrupt sleep more often than knee problems. So patients often, find that their quality of life can be affected more so from shoulder problems. But admittedly, that's kind of a discussion, with the patient on which one is more severe. Because usually one is more severe, not always, but that's kind of just part of the discussion. And then, if patients need a knee replacement, oftentimes they're using a walker or crutches or some assistive device, after surgeries, they may be more reliant on their shoulder and their arm. So they may be putting more stress and may want to do their shoulder first, actually, to kind of get that recovered. So that way they have more support from their upper body, you know, for when they have their knee surgery, if they need to use a walker or a cane or something like that. But yeah, that's kind of a discussion, with each individual patient on their preference and kind of unique circumstances.
Yeah, absolutely. I mean, it's great to hear that if someone is going through multiple injuries that they have to address, that they do have an option. It's collaborative care, both with the patient and their surgeon. Absolutely. Looks like we have a few more questions coming in. When getting a shoulder injection, does it matter if you get it in the front or the back of the shoulder?
Yeah, so there's a couple of places where we do injections around the shoulder. There's kind of three main locations. One is right into the shoulder joint itself. That's typically the one we would do for shoulder arthritis pain. Um, there's also an injection that we do kind of above the rotator cuff. It's called a subacromial injection. Do you see my mouse at all, Lauren?
Yep. Yes.
So, one injection is to put it right inside the shoulder joint itself. That's the most common one that we would do for shoulder arthritis. The other option is to put one we call in the subacromial space or a subacromial injection. That's less common for arthritis because it's kind of more for inflammation or rotator cuff pain. That's more commonly what we would do that one for. And then the other option is to put one into the biceps tendon sheath area. That's more limited or reserved if patients are really having kind of focal pain right in the front of the shoulder. So the majority of them we do actually into the shoulder joint for shoulder arthritis.
That was a great question. Can a person wait too long? And then is there nothing that can be done to help with the shoulder problems if you wait too long?
Yeah, I would say generally speaking, no. We there's always outliers to that. So, in theory, you could have severe wear of the socket to the point where you couldn't, you just wouldn't have enough bone left on the socket to
Mhm.
reconstruct it and do a shoulder replacement. in those kind of unique circumstances, there are custom implants that we can create actually, um, to compensate for some of that. But oftentimes, it's kind of, when the pain is bad enough, people are usually know when they're ready, for a shoulder replacement. So I would say no. In general, it's not bad to, kind of delay surgery
Mm,
as long as
yeah,
your symptoms are manageable.
sure.
And I would say if you're having more bad days than good days, then I think it's time to have a serious discussion about it.
Yeah, absolutely. It doesn't hurt to go in and see what your options are and then
Yeah.
weigh it from there.
Yeah.
Yeah. Should patients be seeing a specific doctor if they don't know if it's diabetic or thyroid issues? This specific person hasn't been diagnosed with anything, but since you mentioned that and it's in her family, she thought she would ask. She has pain traveling from her elbow to her shoulder, and if she does a letter T with her arms, one side hurts. It doesn't seem to be in the shoulder. Could it be a pinched nerve? Just wondering how many nerves are in the shoulder area too.
Yeah, no, it's a good question. We commonly, part of my evaluation, I always evaluate patients. Usually I evaluate their neck, as well, because there's significant overlap between the shoulder and the neck. Commonly though, characteristically, if someone has a pinched nerve in their neck, they'll get pain that radiates all the way down the arm, like into their fingers, and they can get numbness or tingling, all the way down into the fingers. Sometimes they have neck pain, sometimes they don't. But, it's usually something we can tease out, between the exam and their history. And usually some of the provocative maneuvers we do with our exam can help us localize, whether it's the shoulder, whether it's the neck. And sometimes, we get x-rays of both. Sometimes we get x-rays of both the neck and, the shoulder as well. Shoulder pain can often cause pain down the arm as well, but it usually doesn't go, much past the elbow and usually not into the fingers. But there's a lot of different things that can cause that. In terms of thyroid or diabetic, concerns, generally, we would have their primary care doc kind of manage those because those are more kind of chronic medical conditions. But, that's always part of our evaluation too. We ask patients, what kind of medical problems do you have? Because if someone has diabetes, we want that to be well controlled, because it affects, uh, wound healing, tendon healing, infection risk, and if we're thinking about surgery. So, and just for long-term health, we like to have diabetes well controlled. So,
Yeah, great.
so I'm happy to see any shoulder neck problems. I'd probably defer, further lab workup or anything like that to the primary care doc, but that's part of the kind of the comprehensive evaluation too. So we take all that into consideration.
Yeah, that's great insight. How long after injections can surgery be done? So let's just say injections aren't really working
Yeah.
anymore.
Yeah. In general, there's kind of a 3 month waiting period. Yeah.
Okay.
And then that's for shoulders, hips, and knees. In general, it's kind of a 3 month waiting
Mhm.
period. Yeah.
Okay. If cortisone shots haven't worked in an arthritic knee, is it likely to not work in an arthritic shoulder, or is there no way to predict that?
It's a little unpredictable. I think they tend to work better in the knee. That's my personal opinion. Um, it kind of depends too on the severity of the arthritis. We find that if patients have more severe arthritis, and either in the shoulder or in the knee, that the injections just tend to be less efficacious. So they just don't work as well. I think the disease is just more advanced, so they just don't see as much relief. So it kind of just depends a little bit on the severity,
Interesting.
as well.
Hmm. Okay, we've got a couple questions. I'll start with the first one from this one person. What early signs should ATs watch for in tactical or industrial populations that may indicate accelerating joint degeneration?
I think it's a good question. A lot of patients in laborists or manufacturing type jobs, they have a lot of repetitive activities, that they do. And that's part of the ergonomics or trying to, injury prevention is trying to limit, some of these repetitive motions as much as we, can and kind of, um, maintain strength and motion throughout the shoulder. I would say if patients have, again, I think a lot of it comes down to like stiffness. So if they're losing motion, if they're having progressive pain, having a lot of pain at nighttime, I would say more commonly, in kind of the working age population, in manufacturing or industrial jobs, it's more likely or more commonly like rotator cuff issues rather than shoulder arthritis. So usually they still have maintained motion and they may just have kind of achy pain in the shoulder. More commonly, that's kind of an inflammatory issue or more related to the rotator cuff. And that's where I think a lot of the prevention, exercises play a big role in preventing rotator cuff problems. Um, that's kind of my thoughts.
Okay. Is there an age limit on surgery?
Typically, no. Yeah, I would say the majority of patients we're doing shoulder replacements on are in their 60s or 70s.
Mhm.
I would say as a general rule, but we do patients in their 80s, or even their 90s if they're, healthy, active, independent. Yeah. And then on the other end of the spectrum, we do shoulder replacements on people in their 50s, as well. And I think that's where some of the newer technology, like the pyrocarbon, um, is kind of helping to fill that gap for some of our younger patients, that need a shoulder replacement.
And then I have to go back to the part two. Are there any movement patterns or activities that commonly worsen shoulder arthritis but are overlooked in the field?
Um, I don't know that there's anything real specific. I mean, a lot of the overhead activities, repetitive overhead activity, kind of in particular, tends to just be harder on the shoulder joint because I think you see some of the rotator cuff degeneration, which can kind of downstream lead to arthritis. Um, so, so I would say, kind of the repetitive overhead stuff would probably be the most likely to cause shoulder pain.
Okay, awesome. And then we have one last question here. What is your opinion on applying heat and ice?
Yeah, that's a good question too. I think both are good. One hasn't been conclusively shown to be better than another. One strategy that I like is having patients use heat kind of in the morning because it just helps kind of loosen things up. A lot of patients have stiffness, particularly in the morning. And then once they get moving, the shoulder kind of wakes up or warms up a little bit. So I think heat can help with that process. And then using ice kind of towards the end of the day after they've been using the shoulder more, it may be more inflamed. They've been active and doing things. So ice can kind of help, with symptomatic control at that time point. So that's just kind of my general recommendation. But, each patient, some people respond well to one versus the other. So I think it's totally fine to use either, in whichever order they want.
Mhm. Do you have any, talking about your personal recommendations, are there any other recommendations that you would have that you commonly tell your patients that are having shoulder surgery?
No, I think we touched on kind of the majority,
Okay,
of things. Yeah.
wonderful. Well, it looks like that is all the questions that we have. If anyone has any other questions that kind of pop up after this, of course, please feel free to go to visit our website, osmsgb.com. We have a lot of PT protocols, a lot of exercises, blogs that cover a lot of topics. So you'll be able to find a lot of great resources on there. Otherwise, you can also give our office a call at 920-430-8113. And it looks like we have one last question I'll ask you before we
Yeah.
end the presentation. This one got in. I want to make sure we answer it.
All right.
No, that's okay. They're apologizing. It's totally fine. Are there any suggestions in your experience regarding nutrition to prevent or help prior, during, and after surgery?
So like nutrition recommendations.
Yeah.
Yeah. I mean, I think, I think in general, patients, so adequate protein intake is kind of a big one, especially around the time of surgery. If we're talking about like wound healing, trying to minimize complications, trying to maximize muscle mass and recovery. I think protein is critical for that.
Mm-hmm.
And you'll see varying recommendations on that. in terms of how much protein you should be getting. Kind of as a general rule, I think patients should get, 1 gram per kilogram of body weight per day, of protein. So that's kind of a big one. In terms of diet changes, kind of a low inflammatory diet. So patients often talk about like the Mediterranean diet, kind of reducing inflammation. I think just in general, that can reduce inflammation in the shoulder. It can reduce systemic inflammation. Patients often feel better, they move better. Um,
Mhm.
so I think that's really important. And then really, if patients are diabetic, I think really tight glucose control is
Sure.
good, especially around the time of surgery, because we know that diabetes increases our risk of, infection, wound complications, around the time of surgery. So as long as diabetes is controlled, I don't think it increases your risk, as long as it's well controlled. But kind of
Mhm.
maintaining that, particularly around the time of surgery, I think is really important.
Sure. And
There's
one
some
thing,
supplements. I mentioned the turmeric. Some people find collagen, uh, supplementation can be helpful.
mhm.
I don't know if there's a ton of evidence on that, but um, other things like omega threes can be kind of anti-inflammatory as well. So
Yeah. And mentioning the infection rate, I do want to mention that we have an extremely low post-operative infection rate. It is 0.15%, and that is 6 times lower than that of other ambulatory surgery centers and 18 times lower than that of a hospital post-operative infection rate. So you are going to get great care at OSMS. There's no safer place to get your surgery done. In fact, we have been one of America's best surgery centers by Newsweek and Statista for 3 years in a row. So our surgery center has been nationally recognized 3 years in a row because of our quality and safety metrics. So just wanted to throw that out in there since you were talking about our
yeah,
infections.
yeah,
So
yeah, it's something we take very seriously.
absolutely,
We have really good protocols in place to minimize that risk.
absolutely. Yeah. Like I said before, if anyone has any other questions or wants to address any injuries or conditions that they may have, we highly recommend and encourage you to schedule an appointment by going online and scheduling an appointment at osmsgb.com. Otherwise, feel free to give us a call, 920-430-8113, and we can get you an appointment scheduled on the phone. But other than that, thank you for all your thoughtful questions and for joining us tonight. And once again, the recording will be available by next week for you to rewatch or send to anyone at your convenience. Dr. Stradel, thanks again for your time, and we appreciate your insight.
Yeah, absolutely. Anytime.
Yeah, thank you. Have a great night, everyone.
Thanks.